Thanks so much. It's my pleasure to be here today. And I want to let you know, for those of you who saw my talk yesterday, that was some thinking I'd been working on for a while and is a little more developed. Today I'm sharing brand new work with you. So I really want to invite your collaboration to push this thinking forward. And it's my pleasure to be here this week with Dr. Dukas and his colleagues in the department to have this opportunity to think with you in this, and my new colleague, Dr. Lehman, to think with her on this specific topic. I'm going to speak more theoretically about the relationship between law and ethics, and then Dr. Lehman's going to bring a more concrete case to extend that conversation. But they're independent, but there'll be a synthesized presentation and conversation. So I'm really looking forward to this. So let's start. Atticus Finch is a beloved character in American fiction. This noble Southern lawyer represented a black man unfairly charged with raping a white woman, resisted lynch mobs in the name of due process, and insisted on evidence instead of prejudice. And he lost. The jury in this story, as some of you may remember, ignores the evidence and convicts Tom Robinson anyway. To Kill a Mockingbird isn't a heartwarming tale of civil rights. It's a story about law's failure. And I want to share an aside with you. I read this book a million years ago, and that's not how I remembered the ending. There are a lot of lawyers who say this book inspired them to go to law school, but do you ask them how it ended? They remember that Atticus Finch won. He didn't win, right? This is very important for all. So if anyone is laboring under this misimpression or this mismemory from high school, I want to emphasize this. But I emphasize that because today I want to talk about law's failure, or more specifically, how we respond when we believe the law has failed us or failed our community. So I want to start our thinking with what happens in this story after Atticus loses the Tom Robinson case. All right? So at the end of the book, the father of the woman who made the false rape claim against Tom Robinson, Bob Ewell, attacks Atticus's children, scouts dressed in her ham costume, in the woods with a knife. And Boo Radley, a neighbor who seems to have some form of cognitive impairment, defends the children and kills Bob Ewell in the defense of the children. Right? We're on the same page of the story. Now, at first, Atticus thinks his son Jem killed Bob Ewell, and in conversation with Sheriff Heck Tate, greatest name in literature, one of the greatest names in literature, because every time Atticus says, "Oh, heck," you think he's, substituting it for hell, but no, that's his name. And in the conversation with Sheriff Tate, our legal hero immediately turns to the principle that he stood for in the whole book, which is due process and equal justice. So he discusses how he's going to take his son down and turn him in and defend him for killing Bob Ewell, but it's going to be a self-defense discussion. So take a look at this. So the sheriff is offering essentially to, quote, hush this up. And in the passage that follows, to say, let's not go through the court system on this one, right? And in the passage that follows, Atticus offers reasons why they should follow the law, turn his son in, and trust that due process will lead to an acquittal. And that passage really lists out a lot of arguments that we might be familiar with about why one should follow the law. The idea of Jem's reputation. He doesn't want his boy living with this shadow over his head. His long-term benefit, short-term harm to the boy will lead to long-term benefit to his reputation. A utilitarian kind of argument that it will be better for the boy in his interactions with folks in the future that he doesn't have something hushed up. A principalism argument that it'll be a denial to Jem of the way I've tried to raise him if now I cheat in order to get him a benefit. A relational argument that says my kids won't trust me if they see me lie, even if it's for their benefit. They won't trust that I'm telling the truth in the future. And just a virtue argument where he says I can't live one way in town and another way at home. So Atticus lists out all these great reasons that our students of ethics here would be able to recognize why you should follow the law. What I want to offer today is Sheriff Heck Tate's reasons for a cover-up. So the focus shifts. Atticus puts his foot down and says, I won't have it. I won't have a hush-up for my son Jem. And Sheriff Tate shifts the conversation and makes it clear that they're talking about Boo Radley. We're not talking about protecting your son. our cognitively impaired neighbor is the one who killed this man, and that's who we're talking about. So let's take a look at the sheriff's answers. The sheriff constructs a false story about how Bob Ewell fell on his knife, says this is what I want to do. And I want you to just read this passage to yourself. And I haven't read, and I apologize for the smaller text, but tried to highlight for you these counter-arguments that I think for those of you who are clinicians or deal with clinical medicine, you may have encountered with clinicians arguing about, is this something we should open up or take care of ourselves? Whatever that take care of it ourselves mean. The idea that, look, I'm in charge, we've all heard that. The context, I've been in this ward for 20 years. I know how things work. I know how the administration works. I know how these type of patients turn out, fill in the blank. The ethical justification, Boo Radley, you know, is doing the right thing here, and we need to protect him for that. The harm to another of going through this process, the harm to me. I'm the decision maker, and if you force me to just go through these mechanical motions that I think are wrong, that'll hurt me. And this is an exception, and we're going to return to this concept. If it were any other man, it'd be different, but not this man, Mr. Finch. That this case presents an exception to what ordinarily we would all agree in the abstract we ought to do. And importantly, our legal hero, Atticus Finch, who stood for due process in this entire book, concedes. I'm not going to defend Boo Radley and bring this out in the open and trust he'll be acquitted on self-defense and let due process move forward. We're going to just hush this up. Bob Ewell fell on his knife. Right? Vigilantes are people who defy law to further their conception of justice. And I would term the decisions portrayed in this scene as a vigilante acquittal. They don't wait for the legal system to exonerate Boo Radley. They take him off the hook themselves. Now, when people reminisce about To Kill a Mockingbird, the part where the idealistic lawyer abandons the legal system for the midnight decisions of good people who know better is rarely discussed. But as an idealistic lawyer myself, that is the most provocative and difficult part of the story. And to me, that's what makes it a good story to think with. Now, most legal discussions in bioethics are about what the law is or about what the law should be. And I'm in no way disparaging those conversations. I've contributed to many of them, and they're one of the key contributions that lawyers like myself have to make to the field of bioethics. But today, in this talk, I want to open a space for what may be a new area or a new type of depth or nuance in the legal and bioethics conversation about how people are actually living with those laws behind closed doors and how they ought to be living with those laws behind closed doors. And there are two reasons I want to do that with you today and think about this year. And this is a project I'm working on. The first is because physicians do break the law behind closed doors, consciously and intentionally, and often with very good intentions and good reasons. And the second is because I worry about ethics consults and the way ethics consultants are trained and the way the consults themselves are educated. When we identify a conflict between ethics and law in a consult, and then we either just reflexively surrender to the law and we say, well, this great ethics analysis led us here, but it's against the law. Too bad. And we reflexively surrender and walk away. Or what I think is even potentially worse, consultants who say, you know, here's our great ethics analysis. The law says this, but we think it's wrong. We think ethics is more important. Wink, wink. Good luck. Tiptoe out of the room and leave the clinician holding the bag. I think that's inappropriate too. So, in order to completely foreclose any possibility I'll ever be nominated to the Supreme Court, I would like to publicly discuss and reflect on situations in which ethical people might choose to break the law. All right, so that's our project today. As I think I gave you the caveat at the beginning, I'm not going to give you a really terrific answer at the end. We're going to think about this together. The first move I want to make is from them to us. Raise your hand if you've ever intentionally driven over the speed limit, or you drank a beer before you were 21, or you waited tables and didn't report every penny of tips. Raise them really high. Seriously, seriously. Okay, so everyone in this room is a criminal at some level, all right? So let's move from them to us. Human beings make calculated decisions both about enforcement and logic in our law-abidingness. If you always follow the law, if your mother is having a cardiac arrest and you are half-mile from a hospital and the road is completely clear and you don't go over that 30-mile speed limit, I would suggest you might be making the wrong decision. That's a calculated decision that either something more important in this rule right now. If you say that I don't care what the law is ever, I just make up my own mind no matter what, and it's of no, I don't even need to know it, I think you're something of a sociopath, all right? So there's a range here, and my argument and my just premise is that most of us are somewhere between these two ends of the spectrum, and we may have different dispositions, life experiences that lead us to be in a different part of the spectrum, but that this is not just about those other people in those incredibly unusual circumstances. What I want to do is observe something about everyday logic and behavior and human society and move it to more complex and challenging situations. I also want to flag for you linguistically one of my new favorite words, which is the word technically. When you hear people say, well, is that legal? Well, technically it's not. What they mean is, it's illegal, but I don't think you'll get caught if you do it. Right? So if you ever hear someone say, you know, it's technically you're not supposed to do that, stop and ask what's going on there. I think there's this, in our language, we're familiar with this idea of that's a rule you don't have to follow. Recently, a friend was telling me about going to a professional conference, and he said, oh, we were told we can't swap the IDs, you know, in the hallway. We have to do it before we go into the conference. And I said, what do you mean swap the IDs? And he said, well, technically, our business is supposed to pay for each person to attend all day, but we can't go all day, so we swap IDs. And I said, well, when you say technically, what you mean is it's completely against the rules, what you're doing. And he said, well, yeah, but our business is one of the main sponsors of the conference, so our boss told us to do this. So it was we're being told to do this, we don't think this rule is fair, but we instead of challenging it openly, we just swap our IDs. So technically, it's against the rule. So now that you know that, you'll hear it every other day. It's kind of a fun game to play. Like Atticus Finch and Sheriff Tate, sometimes physicians take the law into their own hands, which is code for violating it, for the benefit of patients. And today I want to explore two situations that might prompt an ethical clinician to consider breaking law, and I hope if others come to mind, you'll share them with me in the discussion. The first category I'm going to call the bad law, a law that the physician thinks conflicts with medical ethics overall. And I'm just going to give you a couple potential examples. You might have others, you may disagree with these examples. Illinois has a statute that requires medical personnel to call the police when someone is injured in the course of committing a crime. So the classic example would be someone coming into the ED with a belly full of cocaine balloons. Illinois law says you should break confidentiality and call the police to report this person. And physicians very reasonably say, well, some physicians say my medical ethics analysis leads me to say this is a patient and their confidentiality is prime, and I want future patients to feel safe coming into the emergency room for potential harm to them. I have a decision, a conflict. I think that's a bad law. Right? Many physicians will say that. More controversially, physician-assisted suicide issues, where some clinicians would say, here's a patient I think I should be able to assist in this way at the end of life, and the law tells me I can't, but ethically I think I should be able to. Obviously a very contested issue. Pregnancy termination past the legal limit, where a physician might say, you know, this patient who has these good reasons, is poor, unorganized, has 6 children already, her situation is no different between this week and that week. I don't see this as different. I think my ethical analysis is in conflict with what the legal requirements are. And you can, I'm sure, come up with others. But so this general category of a bad law is one I want to think about. I also want to make another linguistic point. A physician made the point to me once. They said they were talking about in New York State had very high evidentiary standards for end-of-life decision-making, this clear and convincing evidence idea. And she was talking about how working with end-of-life cases, talking to people, being like, I'm sure you had a conversation with your mother in which she said, you know, doing this. And she was explaining this with some pride, saying what we did was a lot of covert civil disobedience. I want to raise for you that the concept of civil disobedience requires the public breaking of the law and the acceptance of the consequence. What they did was a lot of covert law breaking. And again, I'm not saying that was the wrong thing to do. That's for us to discuss. But she framed it as civil disobedience, I think, as a way because there's a social category of acceptable law breaking, and that's what she felt like it was. It was ethical law breaking, and I don't think she had the language for that because we don't talk about this. So in civil disobedience and others, we certainly laud people who defy bad laws openly as an agents of in an effort to make open social change and to trigger debate. It's also the case we have a history, we laud people who defy bad laws clandestinely, whether it's the Underground Railroad or hiding Jews in the attic in World War II. If you did that openly, that would not succeed in policy reform, right? It was the clandestine, the hiddenness of the act is what made it successful. But retrospectively, historically, we laud that hidden law breaking, right? Because we say, oh, historically looking back, we have consensus that those were bad laws. At the time, they were contested laws. So I don't want to suggest we don't have a history of applauding covert law breaking. I just want us to be honest about what it is people are doing. The second category that I'm thinking about is the concept of a good law, but which is one that the clinician might think is generally consistent with medical ethics, but there's a couple exceptions here. One is the fear the good law will be incorrectly applied. And I think the Atticus Finch-Boo Radley situation illustrates this. So in this case, the sheriff in the text you may have noticed says the harm is this shy man will receive cakes from well-intentioned ladies. If that's really the harm, I think we have a due process problem here. I want to invite you, and you can correct me because we're in Louisville, that may be an example of Southern doublespeak. Bob Ewell has friends. And if this outcast of the neighborhood, cognitively impaired person is known to have stabbed him to death. We saw what the jury did with Tom Robinson's claimed violation of mores. I don't think Boo Radley's going to fare well in this neighborhood if this is known, even if the legal system acquits him. And the legal system, the jury of his peers, may not acquit him. So I think that this is an example of that either the law, the application of the otherwise, the sheriff and Atticus Finch are not objecting to the murder law, saying it's okay to murder people, right? They're not saying that's a bad law. They're just saying the self-defense exception is not going to be accurately applied here. So we need to just take care of it ourselves. We think there's going to be incompetent, unfair, or discriminatory application of this law in this circumstance. I want to just suggest to problematize that, Boo Radley, in the way the story is constructed, is wandering the woods at night with a sharpened kitchen knife. Are we really sure that this guy isn't dangerous, or what is he doing there? And Scout also says we never saw him again, and it's not clear why that is. So I think there's a lot of complexity built into the story, but that's the decision that they made. A second is this case is an exception. Like, I agree with the law generally. I think it is consistent with medical ethics. I'm not looking for a rule change. I'm looking for kind of a safety valve. This case doesn't quite fit the model. Again, someone might say, I actually think the ban on PAS in most states is appropriate, but this case is just extraordinary, and it feels like an exception. This is similarly with the abortion example. I think that in the interest of time, I'm not going to go into too much depth here, but the case of Dr. Anna Poe and Katrina, there was some outcry, the idea that she would even be brought before a grand jury. And I think no one would have suggested, oh, it was up to her, anything goes. If you're in an emergency, you can line people up and shoot them and pick them any way you want. And no one was suggesting that the laws against murder didn't apply to her just because it was an emergency. I think the claim, the embedded claim, was this was an exception. It wasn't the kind of case that that law anticipated or was intended for, and therefore to bring her in front of a grand jury with that framing was inappropriate, was the argument many made, and we can discuss that if that's something people want to get into. Actually, last night in the master's students that Dr. Dukas taught, an example came up that I thought was fantastic. They were a wonderful group of students, very smart and very well studied, and someone brought the example of a Kentucky statute. The case involved a 94-year-old prison inmate who had some important decisions to be made medically and was having dementia, and the team decided he didn't have capacity, and the question was, well, who will be his decision maker? And he had been in jail for some number of years, but the Kentucky statute prohibits inmates from being proxies. Now, what I was arguing to them was that's the legal standard. Inmate can't be proxy. But the reason for that statute is if my daughter's in jail and I name her as my health care proxy, you're not going to be able to get her on the phone quickly. She's certainly not going to be able to come to my bedside and see me and figure out what's going on and make these decisions. Maybe that says something about how in touch we're able to be generally. Will she know my wishes? There's some good reasons you could suggest to not have inmates be health care proxies. I'm guessing that statute didn't anticipate that this other inmate was my roommate for 20 years and he knows me best. Right? So that's an example. I might say that case is an exception. Ethically, his cellmate, if we say learn that's his best friend who knows all his wishes, might be ethically the right decision maker, even though the law says he cannot be the decision maker. I might argue, under this rubric, that case might be an exception where you'd say, I'm going to listen to this guy anyway. I'm going to let him be the decision maker. So that was a case that came up last night in our ethics course. So the case the law didn't anticipate. So I want to raise this issue, and I think this is what's raised by this exception. Is it possible that violating the law in this kind of circumstance is a way to both have system efficacy and predictability, like yes, generally this is the statute that you have to follow, and to have a safety valve for justice in aberrant individual cases that don't have the same features that led to the policy in the first place? I think that's the argument there that, of course, people are not having explicitly, but that is embedded in this situation. So, to come to my close, the question becomes, when is law breaking an exercise of clinical judgment, and when is it an act of arrogance? How might clinicians and medical ethicists think systematically about if and when law breaking is ever an ethical choice? The question that I'm working on this year is, could we as ethicists and physicians reach consensus on guidelines for moral agency in the face of legal prohibitions? All right? So I want to share with you some preliminary thinking on this, things we might think about. First is who benefits from this law breaking. If I cheat on my taxes to benefit my own pocketbook, I can make all sorts of justice arguments about the government's overtaxing me, and they're really less convincing, right? By definition, when physicians are considering breaking the law on behalf of a patient, we're already in a good place in terms of conflicts of interest, which I think is very important to note. To go back to our Atticus Finch example, when it's his own son, he argues vigorously, we will not do this. When it's the more vulnerable neighbor, he's more interested, he's more open to the sheriff's arguments, and I think that that's relevant. The second is, who's the victim of the violation? Is it a person or a principle? So if I say, well, I disagree with research laws that say I have to get informed consent from this patient. You know, I'm going to do something that might be harmful to this patient, but it's to benefit other people. We've really got a person on the line here. So it's really got skin in the game. Versus one could argue in physician-assisted suicide, if I have a patient who's begging me to end their life a few days early because they're in pain we are not able to treat, or they're suffering in this existential way that they feel like has undermined their entire life and who they are, there's a potential slippery slope there, obviously. There's a lot of concerns, and we can unpack that example. But some would argue there's a principle on the other side of the balance, not another human being that's being harmed. And that would be relevant to me in this analysis. Not necessarily determinative, but certainly relevant. Consequences of this violation are a really interesting thing to think about. And also, what level of probability? How do we know that consequence will flow? Is a really complex analysis. Consequences for the patient. Future patients in the demographic, and I think Dr. Lehman will probably speak to this, but in HIV you might say, this disclosure with this couple feels really right to me. But wait a minute, what about the population of future patients who might come to our clinic? How might it harm them if I make a disclosure here that leads other people to not get tested and come get treatment and that sort of thing? So thinking about benefit to whom, and again, what degree of probability or certainty do I have that harm will or won't flow to this patient or to populations? Harm to myself as a clinician. What kind of legal liability am I exposed to, and how do I factor that in? I won't be able to treat future patients if I lose my license, so no matter what good I do for this patient, how do I weigh that? And this concept of our community generally, I think is worth talking about. Who is our community? How do you get your thinking out to concentric circles? To whom do you owe responsibilities? Are difficult things to think about. The risks of this are certainly multiple, and we can talk about these in our conversation. Certainly the arrogant or ignorant application of these laws, principles. I don't see the other consequences that might flow from this. The idea that I'm above the law, I always know better, right? It's also the case that secrecy limits information gathering. In my field, what we call discovery in the legal process. So how do you know what these are? We don't have the open, robust exchange of information that in an idealized legislative debate we might have, where people get to come say their point of view, we get to hear about from different parts of the community and make a more open assessment of what might flow from these decisions. And also the lack of an adversarial process. There is something I'll tell you as a lawyer, that when you get up there and argue and you say, I'm just going to take this side of the question, someone else will take this side of the question, there is something that comes out of that that's different than when one person says, I'm going to weigh the pros and cons. I know from experience there is, and can be something very productive of that. And lastly, I'll say in terms of risks, even if this was done well and someone who's really heart is in the right place doing a very sophisticated analysis, there's no review, there's no appeal to whatever that decision is because of the secrecy in which this happens. So those are good reasons to not even get involved in this, or they are good reasons to be very careful about this, depending on your point of view. My last point, I want to end with a cautionary tale about the seriousness of these decisions, lest anyone think I'm being cavalier about this idea of law breaking. And I want to end with another Southern murder, this one not fictional, sadly, that happened 5 years before Mockingbird. None of us, everyone I hope in this room is familiar with the horrible story of Emmett Till. And none of us good ethical people want to be associated with these monsters who committed this crime, but the stark reality is that vigilante acquittals are the mirror image of vigilante punishments. In both cases, private citizens made powerful by inside information and secrecy or brute force decide that following the law would lead to what they believe is injustice. They feel the law is not handling a situation appropriately, and they take the law into their own hands. The one difference is that in the Atticus Finch story, what they're saying, example is, they're saying the law does allow for self-defense. What we're stepping away from is due process. We're applying the law as it is, because we think the due process, the application of it, will be wrong. In the Emmett Till situation, the murderers confessed in a magazine their motivations or discussed what was going through their mind. The law that says there's no law against whistling at anybody, they thought that was incorrect. The law as it stood was incorrect. They were going to enforce a different law with horrific consequences. So there is that distinction. But the point I'm making with this, so I'm not saying they're equivalent, but the point I want to make with this to end on is that private conceptions of justice are exactly that, private. And by definition, they're idiosyncratic to individuals or subgroups, because if they were widely shared, they'd probably be the law, right? And that is the conundrum that I'd like ethicists to help physicians and patients reckon with. Some of you may have been shocked by examples I used and thought, that's not justice, the exceptions or examples she's giving, but that's because you and I might have different conceptions of what the right thing to do in complex circumstances might be. So that's what's at stake in these situations. I'm not suggesting one definitive way of handling them or another. What I'm suggesting is the error is to pretend they don't exist and to fail to discuss them. Thank you very much.
Thank you for inviting me here, and Katie, thank you very much for that really interesting analysis of how to deal with this potential conflict between ethics and the law. What I wanted to share with you to begin with is a case which I thought was here. Just bear with me. I don't know where it went. No.
Button next to the Word document you just opened. There you go.
Okay, great, thank you.
There you go. On the right.
Yep.
One on the right. Right side.
Okay, so this is a case from our HIV clinic, actually, where a patient named Gary was a wealthy man with many connections in the community. He was involved in a complex relationship with Jose, who's an undocumented immigrant. So just note there a significant power imbalance, both in terms of wealth as well as legal status within the society. When Gary learns that he is HIV positive, he immediately blames his partner Jose for being the source of his infection and accuses him of infidelity. But he doesn't share his HIV status with Jose, and he says that instead he tells Jose that he has syphilis and suggests that he get tested, that Jose go and get tested, admitting that he has an ulterior motive, that when Jose goes to the clinic, the infectious disease clinic, or to his primary care doctor and goes and gets tested for syphilis, another sexually transmitted disease, he'll also hopefully get tested for HIV. And so that's indeed what happens, and the partner comes in, he meets with a social worker who's able to assess that there's extensive domestic violence at play, and that's made much worse by this power differential between these two people. So at this point, Jose is coming into the HIV clinic and meeting with the HIV social worker. That may not have been entirely clear there. And the social worker realizes that Jose is actually not able to freely leave the relationship with Gary because he's afraid that he might get deported if he does, that if he threatens to leave, there'll be harsh consequences both for him and his family and his friends. So the social worker actually goes on to explore with Jose his perceptions of risk and encourages safer sex, right, as any good counselor would do. And as they begin to further discuss this, it's clear that to the social worker that Jose is completely unaware that his partner, Gary, is actually HIV positive. She didn't realize this at this point. Jose's does undergo HIV testing. It turns out that he's actually negative. And the social worker continues to work with him around the domestic violence issues in an effort to try and bridge him to other services. And on one occasion, during their conversation, Jose actually revealed to the social worker that his partner Gary forced him to have sex and refused to use a condom. So the social worker now, and also the clinicians in this clinic, who are, it's a very coordinated practice where the social workers play a tremendous role in terms of figuring out what's going on with patients, but there's a tremendous amount of communication with the clinicians also. So the social worker and the infectious disease doctors taking care of Jose and Gary, they're both being taken care of in the same clinic, are now in this very difficult situation of having a patient who they know one of them is HIV positive, they know that partner, and they're also taking care of that partner who is at risk of becoming HIV positive. And they feel as if they're really uncertain about how to handle this. And the reason why they're uncertain about how to handle this has to do with the law in Massachusetts. So I'm from Boston, and this is a state, every state has a different approach to this issue of the confidentiality of HIV test results. And I'll share with you what the law is in Massachusetts, but the first question I think really is that these clinicians are confronted with is it ethical to breach patient confidentiality and share Gary's HIV status with Jose? Is that okay? And what are the arguments for and against breaching confidentiality? If it is ethical, how should we do it? And what do we do about this legal question about whether or not it's legal to breach confidentiality, and how should the answer to that legal question enter into our decision making about what we do in this case in particular? So I actually would like to open it up a little bit, and I'd like to hear what people think they would do in this circumstance. Any thoughts? Yeah, Paul.
Well, can I ask a separate question? What's the law in Massachusetts about reporting rape? Because that's what was just reported to the social worker. There's another issue of breaching confidentiality there, where abuse can be, you're more likely to be able to violate confidentiality for abuse.
Right. It's a great question. What's the law with regard to reporting rape? I honestly don't know the answer to that. Katie, please.
Specifically, there's not only no mandatory reporting of that, it's prohibited in the understanding that adults get to choose whether to report assaults against them or not and weigh the consequences of either decision.
But I'm not sure, though. I mean, it's a really interesting question, and you're right that this case raises that question. It's not clear to me that the answer to that question, though, really sheds light on what we do with regard to the HIV status, right? They're two different questions. Yes.
I had a case like this about 10, 15 years ago. He was a man with carcinoma of the anus and multiple palpable paraclavicular lymph nodes. I wondered whether he also had TB. As I worked him up, I found he was HIV positive. And he had a living girlfriend. And when I asked him if he had informed the girlfriend about his HIV status, he told me he hadn't, and that he forbade me to, that it was none of my business to disclose the information. What I remember at that time was reading about a case called Tassaroff versus Regents.
Right.
The right to privacy versus the duty to protect, and the patient vaguely threatened me that I'd be breaching his confidentiality if I told the girlfriend, which I proceeded to do, and told her that her boyfriend was HIV positive, that she needed to be tested, and that she needed to avoid sexual contact or needle sharing with him.
Okay, great. So you had a very similar case, and you came to the decision that the right thing to do was to breach confidentiality, even in the face of the patient telling you, no, I don't want you to do this. And it sounds like part of what persuaded you to do this was this legal case, the Tarasov case, which is really the basis of this idea of the duty to warn. That the Tarasov case actually was a case involving a psychologist, in which the psychologist was told that by their patient that they were going to go ahead and kill someone, and out of concern for the confidentiality of the physician-patient relationship, the psychologist chose not to warn that victim. The patient then went ahead and actually killed that person that they said they were going to kill, and the court said, no, there really was, patient confidentiality here did not override your duty to warn in the case of imminent threat of death or harm. And so one of the interesting questions, I think, about thinking about that legal case of Tarasov as an analogy for our thinking about this is the imminence of the harm. And certainly HIV, at this point, is a chronic disease, and it's no longer a death sentence, but certainly a very serious disease, right? And certainly something that we should try and prevent if we can. But we might wonder whether or not it's a perfect analogy to that kind of someone's going to kill someone, and is the threat of HIV really equivalent? I don't know the answer to that, but and I'm not sure it makes a huge difference, but I think it's worth thinking about.
At the time, I think I said it was 50 years ago. It may have been longer. Memory failed. At the time, I remember thinking truly an imminent threat to the life and safety of this unknown woman. This was before triple anti-RIF.
Right.
When I was first practicing, it was this vague, we used to call it the vague disease from San Francisco. We didn't know what this was. We knew it was bad, and people died within a few days of being admitted to the hospital. But if the case came in today, and someone tried on me the chronic disease argument, I think I'd probably still reject it. Still, I would have called her.
Right. And was this in Kentucky? Can I ask? Is this?
North Carolina.
And do you know what the law was there at that point, or was that even a consideration in your mind?
No, I don't know what it was, and no, it wasn't a consideration. Apropos the previous speaker, I don't remember even bothering to ask what the law was. I probably would have said something like, if this is the worst crime that I committed, so I'll ask for forgiveness on the Day of Atonement, do what I think is right anyway.
So I think this is really phenomenal, because this issue has come up in our institution multiple times. This is not the only case we've had of this. And I think that the first question that clinicians ask is this legal? Is this okay? Can I do this? From a legal perspective, it's at the forefront of their mind, in part because I'm not sure that it's this tremendous desire to not violate the law, but it's out of concern for potentially being sued if you do violate the law. I think that that's partially what's driving it. Yes?
I'm a psychiatrist, and I had been working in the HIV clinic here. And we were fortunate enough to have a Ryan White grant, which allowed us to have an attorney work with us. And it's because there were many, many legal questions that came up. But what we found is the ethics and the undercurrent of the sexual nature of HIV caused a lot of moral questions to be thrown in too. We had this all the time where patients would be positive and would be in sexual relationships, and it would really part of the affect of what happened would occur if someone was having sexual relations with someone in a steady relationship, or if they were having relations with someone who was then married to someone else in another relationship. So the complexity of the possibility of transmission affected a lot of decision making. But in Kentucky at the time, and it's been several years, our law stated that you could not disclose unless there had been a cohabitation for a year.
Right.
And unless that was changed as what the law was.
Right. And so despite that law, what's been the practice then in the clinic? I'm sorry if I wasn't clear on that. How have you handled these difficult cases then, in a situation where they don't fit into that law of being at least a year of cohabitation?
To my recollection, was not disclosed. There would be an effort to have group sessions, family sessions, get the people together to work, to help them process it, to make that decision themselves.
Right. Yes, David.
Different jurisdictions are different. So I remember 22 years ago when I was a rounding physician at Providence Hospital, we had a patient who was admitted with cytolysis with a possible endocarditis. And we soon found out that he was HIV positive, and I found out that he was married. We quickly found out, too, that the wife was also pregnant. And so I called up my partner who took care of this woman and said, has she been HIV tested? Well, we did the mandatory, required request, but she declined. And I said, well, might you think it a good idea to now, because I told him about the patient's HIV status, and that the patient himself said, I'm going to continue to have sex, I forbid you to tell my wife. So in talking to the doctor, my partner, he said, well, we need to go ahead and have him tell her. I said, well, I think you may be on shaky ground right now, because he's saying no. And this is when it was a lethal disease. There were no retrovirals to go ahead and tell you've got HIV, you died. And so I said, well, there is one way you can do something here. You know he is an IV drug user, which he was. That's how he got the cellulitis and the endocarditis concern. She knows he's a drug user. Say, on reflection of the fact that he's in the hospital, he's obviously an active IV drug user, I think it's a good idea for you to get the HIV test. This would be a way of trying to do a little bit of a finesse to get the testing done without having to do the divulging. He said, no, I'm not going to do that. And he went on into the hospital with the wife in tow, and he said to the guy, if you don't tell her, I'm gonna. And then the guy went ahead and said, I got HIV. And she went, big surprise. And so she got tested and was ultimately negative. But this doctor also did a very bizarre move. Katie can perhaps comment on this. He then went to court and tried to cover his own rear and to say that it was a permitted act to make the divulging of this the way he did in the hospital. And the judge went ahead, and this is in D.C., which has a different perspective on such things. A, the fetus had no rights or claims because it was a fetus. It was at 21 weeks. And B, she had no claim because there was no imminent, irreversible, lethal harm that was about to be done to her. In other words, the imminence part of it was not held. So he basically threw the entire...
Well, that's not... Why do you say that? I mean...
Given the fact that he says he's going to continue to have sex, that's not the same as saying, I have a gun and I'm going to shoot someone.
Right, so that gets back to the issue that we were talking about earlier about whether or not the Tarasoff case is actually a valid analogy for thinking about the transmission of HIV through sexual contact. I share your perspective that even if it's not a perfect analogy, We as clinicians have a very strong obligation to prevent the development of a serious disease that's completely preventable with an awareness of it. So to say that it's not imminent harm, I think is problematic, or it's at least not a good enough reason to not feel strongly that you should still disclose this. But let's go on. I want to encourage us to just reflect for a moment first on why is confidentiality important? I mean, I think before we can sort of say, well, you know, should we breach confidentiality or not, we have to really understand, well, what's the significance of confidentiality? Why does it matter? Why are there these laws in some states that circumscribe physicians' actions with regard to disclosure of medical information? Paul.
Makes medicine work. Confidentiality is necessary for trust. Trust is necessary for medicine to work. That's why it's there.
Okay, so patient trust, societal trust, it's necessary in order for us to do our job as clinicians, or else patients won't share information with us, and we won't be able to take good care of them if they don't feel comfortable divulging things. Any other reasons why confidentiality matters?
To support that, it's also minimizing harm. The idea that if people don't trust, don't come, and don't get treatment, harm flows from that also, both to them and with the case of infectious diseases, when they pass on their diseases. So you can still make the harm, utilitarian harm argument.
Right. So you could make an argument that confidentiality actually prevents harm or minimizes harm by encouraging people to seek treatment. And I think that's one of the big concerns with HIV, certainly in the early 1980s, when many of these laws were actually developed, was that if we are not very, very clear that confidentiality in these cases is absolute, that we will not breach confidentiality, then patients won't come to us and seek treatment for they won't even get tested for HIV, and they won't seek treatment for HIV, and that will result in more harm. It's not just a matter of eroding trust, but it's actually going to have an impact from a medical perspective on the care that they're going to receive or not receive potentially. Paul.
Another issue is the social dimension of the patient's well-being. Such as reporting HIV may affect whether or not one keeps a job, or reporting other kinds of threat if they make the individual quite nervous in social situations, such as reporting a woman's abortion, which she is trying to keep secret because she's professional, she's in a family where that's very controversial. But if somebody should report that, it'd be very, very damaging to her. But that's the social context.
Right. So, and that's really important too. That there's potentially a social stigma associated with HIV, with a diagnosis of HIV, and therefore, if we don't maintain the confidentiality of that information, we may open up people to discrimination and to just stigmatization within their family structures, within their communities, and within their jobs also. So I think we talked about most of these. One is that it establishes trust. It's a respect for privacy and the sharing of intimate knowledge with a patient. Patient's medical information is obtained with patient's cooperation and consent, and so the patient therefore has a right to control to whom it is given. We talked about it minimizing the chance for discrimination, and also the idea that it actually encourages rather than deters patients from seeking beneficial health care. Although I would note that we don't really know whether or not that is, if there's a good empirical evidence to support that idea. There's also a promise of confidentiality, I think, in the context of the physician-patient relationship, right? There's an assumption that patients make about confidentiality and the information that is being shared with that physician. And we have to ask ourselves if that promise actually creates obligations that might not otherwise be there. And sometimes those promises can be implicit or explicit. But doctors rarely explicitly promise confidentiality to patients, and I would say it's much more implicit in the relationship. And the law actually, I think, reinforces that commitment or promise, right? It emphasizes the fact that that information is confidential, even if at any, maybe at no point during an encounter with a patient do you explicitly discuss confidentiality until it becomes an issue, like where you want to breach it. And it's at that point then you start talking about it explicitly. So what are some limits to confidentiality? And I think that this gets to some of the issues that Katie was raising in terms of our assessment about when we think about breaking the law, what should influence our thinking about that. And I think similarly, when we think about, well, are there any limits to confidentiality, just more from a philosophical or clinical perspective and not necessarily from a legal perspective. But we certainly know that in some circumstances, promises can justifiably be broken. So just because there was this promise of confidentiality within the context of the physician-patient relationship doesn't mean that you never break a promise, right? Sometimes there's good justification for doing that. And sometimes even though someone has a right to information or a right to something, that doesn't mean that it can't be justifiably infringed. So I think that the first limit potentially on confidentiality is preventing harm to someone else, to another patient or another person. And the Tarasoff case is an example of that, where in that case it was the issue of preventing harm to someone who is going to be killed, or we might have a suicidal patient. And in that case, we might say we need to breach confidentiality in order to protect that patient. A second limit might be to prevent harm to others. So the first one was really preventing harm to the patient, him or herself. And when we think about preventing harm to others, society has actually asked doctors, I think, to assume a second professional responsibility, and that's to the public good or the public welfare. It's not just about the patient in front of you, but you as a physician actually have a responsibility to the public health. We're concerned about this patient that is refusing to share their HIV status, transmitting HIV to many, many more people in our society. And if you can identify those potential people that you may, that this person may actually be transmitting that infectious disease to, then you as the clinician actually may have an obligation to society, to the public welfare, to breach that confidentiality and try and prevent that transmission of that infectious disease.
Lisa.
Yep.
So in Massachusetts, you have a public health department, do you not?
Yes.
And you have a mechanism by which the physicians report to the public health department when HIV status is positive.
Yes, but that doesn't necessarily imply a tracking and a disclosure on the part of the public health department.
They do not.
They do not.
Contact, right?
They do not do that.
They're just doing it epidemiologically.
Exactly.
Oh.
I want to throw out a third idea in terms of a limit on confidentiality, is that maybe in some circumstances an individual can forfeits their claim to confidentiality. And that would be, I think, maybe also an additional reason in terms of when we think back to the case that I presented at the outset, where there's what I would consider to be a tremendous amount of disrespect and an absence of any moral concern for this person's partner. And there's an intentional desire to inflict harm on his partner. Gary is intentionally trying to harm his partner and trying to make it seem as if Jose actually was the source of his own HIV. Yes?
Is there anything you can do with patients who seem to be abusive and intentionally harming other people? Is there therapy? Is there something? Are you obligated to report them legally? There seems like a big problem.
Right, so I think that gets back to the question that Paul raised earlier, which is about mandatory reporting for abuse. As Katie said, that it's typically not the case that there's mandatory reporting and you leave that up to the individual. But at the same time, that doesn't mean that there aren't things that we can do as clinicians to help provide more social support and encouragement for people in order to get out of those relationships that are abusive. So I think you're raising a really important question. It doesn't, even if we go down that route, we're still left with this fundamental question about what do we do about the confidentiality of this information, and the fact that if we actually decide to breach that confidentiality, we may be preventing harm in this other patient or in other people.
Is there anything you can say to the abusive patient? I don't try to get their attention. Is there any sort of standards with
Well,
Or do people just kind of hands off their abusive work and ignoring them, we're going to put because I'm the victim?
No, I think there is a standard, and I was going to talk about that at the end in terms of how to approach this. I think there's a clear consensus that you absolutely have to go out of your way to try and persuade the person who's doing the abusing to disclose their HIV status and to try and persuade them that their behavior is wrong. But in, like, your case also, David, very frequently people are not particularly receptive to that information. What's interesting about the case that you shared actually is that the physician didn't breach confidentiality himself.
No,
he threatened and created the environment in which the person felt. I wouldn't say I don't know if he coerced. I mean, but he certainly induced the person. It's fair.
It's a good word.
Yeah.
At least at one end of the spectrum, I think we are learning the entire administration of Penn State might fall because reporting child abuse trumps everything else. There is no excuse, it's not only reporting it, but you have to follow up on the report and make sure something is being done about it.
So is it the abuse part of this case that is driving your thinking, or is it the reporting of the HIV status?
No. This is if you're required. I don't know how many things David knows is what you have to report, but we're constantly on the IRB putting into consent forms. You will be tested, and if we find X, it will be reported. I don't know all the things that the Kentucky requires reporting, but there are a number of things that every subject is told.
Okay. Yes.
I've seen it transition in your third limit in my time in practice. When I first started practicing, adults with brain tumors who had seizure disorders continued to drive automobiles. There was no one to report it to, and you could give the patient a stern lecture. They might be endangering others, but there was nothing you could do about it. Then, after about 15 years, the laws changed, and I was required to report to the motor vehicle department that I had someone with uncontrolled seizures who was endangering other people on the road, and therefore had violated their right to privacy by me turning them in. Although, in my practice, what I would tell people is, you need to stop driving, because if you don't, you're going to force me into a position where I have to turn you into the motor vehicle agency. Let's not do that. You're going to hand in your license.
Right. That's another great example. Yes.
I'm concerned about the case that David brought up with the woman who is pregnant. There's a third person now.
Yes.
And no one's talking about that. And now that child could be born with HIV.
Right.
Or it could try to be brought up by two HIV parents.
Right. That was an interesting case. It would have been more interesting if it was occurring today, where we had treatment to prevent the development of HIV in that fetus. But that wasn't the case there. So in some ways, the implications of the disclosure at that point to the fetus were really not that significant. So we do have to be concerned about that third person, that fetus, in terms of if the mother is HIV positive. But there isn't anything that you would do differently at that point.
But it was relevant because she could have still had an termination if she wanted.
If she chose to.
And that was why there was some time constraint that you can't wait. We need to either do this now or not.
Right, Paul.
I also would make an urgency in letting and encouraging that she knows that he is, so that she could then say, all right, if I'm negative now, I'm not going to have unprotected sex with you anymore.
Oh, absolutely. I mean, that's the same issue. Yeah. Right, absolutely.
I think we're illustrating something that needs to be underscored in the patient-physician relationship. No patient has a commitment or an assurance of absolute confidentiality. And no physician has an absolute commitment to making absolute confidentiality. There are limits, both legal and moral, to that. And that needs to be a part of the patient-physician contract.
There isn't a clear consensus about that. I mean, it may be very clear in your mind, but I think there's a lot of wisdom in what you're suggesting. But I don't think that it's necessarily clear to all physicians or to all patients, for that matter. Yes.
I think it's important to note, it seems like we've been talking about the two separately, the reporting of HIV status and the abuse. And really, the failure to report the HIV status and the continuation to have unprotected status is a continuation of that abuse.
Right, it's a form of abuse in some ways. That's correct. But the reason why I'm extracting it and focusing on the reporting of HIV primarily is because that's, I think, where the greater conflict is between the law and the ethics. Okay? So that's sort of the practical point. But Katie?
I'm really intrigued by this, the idea that who forfeits their right to confidentiality. And what I love is the Part A and Part B in your slide. So some people forfeit their right to confidentiality. I am very sympathetic to your subpart of those who fail to show moral concern for others. My concern is that others would have different reasoning. Who forfeits their claim to confidentiality? The unpopular people in our community. The people I think are not worthwhile or not worthy of my respect. You've got a great reason for who might forfeit. But once we start making exceptions of who forfeits, I'm not as secure that everyone will have the criteria, the wonderful criteria you have versus a bright line rule.
Right.
I think that's another concern, though I'm very sympathetic in this category, as a practical thing, I have a concern about its application.
Right. Good. So what does the AMA say about this whole issue? So this is an excerpt from the AMA policy. If a physician knows that a seropositive individual is HIV seropositive individual is endangering a third party, the physician should, within the constraints of the law, whatever that means, right? That's an interesting phrase. First, attempt to persuade the patient to stop, and that's what gets to your point as, you know, what's the process here and how should we approach this, and where is this effort that we should be making to try and convince the patient that this is wrong. If persuasion fails, to notify authorities, and if authorities take no action, then to notify the endangered third party.
So what does it mean? What does it mean, notify authorities? So I call the sheriff's office and they're supposed to go beat on this guy's door?
No. Notify Department of Public Health. Okay, that's what I think that's what that refers to.
The contradiction within it is obviously within the constraints of the law, when the law tells you you can't do step 3.
Right, the Department of Public, and not only that, the Department of Public, right, exactly. I mean, the Department of Public Health may not be doing it in part because there's a law also that is constraining them. So the AMA policy goes on to say that in collaboration with state medical societies that they support legislation on physicians' right to exercise ethical and clinical judgment regarding whether or not to warn unsuspecting and endangered sexual or needle-sharing partners of HIV-infected patients. So they are leaning towards this idea of a duty to warn, and they promulgate the standard that a physician attempt to persuade an HIV-infected patient to cease all activities that endanger unsuspecting others and to inform those whom he or she might have infected. If such persuasion fails, the physician should pursue notification through means other than by reliance on the patient, such as the public health department, or by the physician directly. So a further elaboration of that idea. So this is the Massachusetts law, and it was developed in 1986, and I think that the timing of that law is important. It is still the law, however. But that was at a time when HIV was not a nearly as treatable a disease as it is today. And I think it was also at a time when HIV carried an even greater stigma than it does today. I mean, today we have patients who are HIV positive that are getting IVF and having children. Right, and so there are, you know, a lot has changed since 1986 in terms of the life expectancy and the attitude towards HIV in our society. But the law that was developed in 1986 is that prohibits physicians and healthcare facilities from disclosing an HIV patient status without the patient's written informed consent. And providers and/or healthcare facilities who violate the provision of this statute are subject to a civil suit. So it's a very absolute and it's very explicit. And it doesn't really give any leeway to clinicians in this, under this kind of circumstance. The AIDS Law Project goes on to say, deals with this question about whether or not there's ever an obligation to disclose, to warn a third party about a patient's HIV status. And what they say is that there's no clear justification for a breach of confidentiality under Massachusetts law. And even that if a physician or a social worker is completely aware that a patient is engaging in unsafe sex or other risky behavior without having disclosed it to their HIV positive status, and you can identify that person, you're still not justified in going there and sharing that information. So what about Kentucky? Kentucky law says that physicians may actually disclose this information to spouses, and that physicians may disclose it to a partner who has been living together for greater than 1 year, as was said earlier. But
without permission of the patient.
Without permission, you may disclose it. You're not obligated to, and I think that's an interesting distinction between an ethical duty or an ethical obligation and permission to do this. And there's no requirement that they actually disclose it, but there is permission there in certain circumstances. I don't really know why this distinction between a spouse and other sexual partners, or why the sexual partner has to be someone that you're living with for greater than 1 year. It doesn't make a whole lot of sense to me. It seems like if you know that this person is really having sex with someone else and you can identify that person, then that's where the permission should come. It doesn't, and especially since the law is written in such a way that there's only a permission and not a duty, I could see the concern on the part of clinicians that if this were written as there's an obligation, then the challenges logistically for clinicians of tracking down people and doing this would be potentially burdensome. So when I want to come back to our case and think about how we might deal with this, because I think certainly in the state of Massachusetts and even in Kentucky, there are going to be cases where there's going to be this conflict with what many people would say is the ethically justified thing to do, which is to disclose HIV status against a patient's wishes, and what the law says to do. And so patient's confidentiality, I think, should be maintained, except for one where there's clear and serious harm to the patient, or there's clear and serious harm to others. And I think that the case that we talked about is a good example of that, in addition to the abuse that's occurring, but the serious harm. And that provides an ethical justification for breaching confidentiality. I think that, to go back to some of the thoughts that Katie shared with us earlier in terms of how to think about this conflict between ethics and the law, and those questions about, well, who's benefiting from the law breaking? Clearly in this case, when I as a clinician decide to breach confidentiality in the face of that Massachusetts law, which is absolute, not only am I not benefiting from that, I am actually probably putting myself at significant risk. The institution I may also be putting my institution at risk, which is another interesting question about how that should factor into my decision making, and whether the institution should be telling me not to disclose if I think that's the right thing to do, because their interpretation of the law is such that this is not ethically justified or legally justified. And then this other question about who's the victim of the violation, right? It's clear that in this case that I shared, the first case, the victim is someone who's vulnerable, who's disempowered, and has tremendous reasons to not, from a social perspective, to be concerned about doing anything that would go against his partner's wishes. So I think the victim is not a principle here. I mean, the victim is, on some level, there's the principle of confidentiality, but if we're willing to say that that principle is not absolute, then the victim in many ways is this person before us who's extremely vulnerable, and we should be asking ourselves if we as clinicians have an obligation to that vulnerable patient. And then there's this question about, well, what are the consequences of the violation? And the consequences are broad, right? I think it's pretty clear that there's a high level of certainty and probability that if continued unprotected sex occurs, that HIV is likely to be transmitted. There's a high risk of that. And there's consequences of violating confidentiality in terms of my relationship with Gary, right, in that he may refuse to come back to our HIV clinic. And it may threaten the HIV population's attitude towards HIV care at our hospital. And that may be a bad thing, right? That may be bad for the population of HIV-positive patients within our community. But I think that the real question is, well, do those concerns outweigh my concerns and my ability to prevent significant and serious harm to this other patient, to Jose? And as I think about that, I guess I share the the inclinations of your dean, that this is really something that we are justified from an ethical perspective in violating the law, and there's good reason to really prevent this very serious illness, even if it might not be as life-threatening or life-limiting as it was 20 years ago. It's still not something that it's something that we should try and prevent if we can. So I'll stop there, and I'd love to open it up for questions here if other people think about this differently, and invite Katie to come back up, and we can reflect more on this issue of how the law and ethics interact in these kinds of cases. Questions? Paul.
Let me ask
Steve. I'm sorry. Why I keep saying that?
Let me ask Katie a question about hectate. The way that I interpret that speech is, or it could be interpreted as a statement of the virtues of the practice of being a sheriff. In other words, he says, I'm not a good man, but I am the sheriff. Thus he's defining not just his role, but also the context in which he's acting. And he's saying what a good sheriff would do under these circumstances is the following. And whether or not the correct answer is neither here nor there. And thus, he'd be describing something of a virtue-based way of addressing this, and a practice-based, virtue-based way of addressing this, which has its problems, but I think is an interesting way to try and address these kinds of questions. Not what's my role ethically in society, but what's my role as an ethical clinician.
Yep.
I'm going to throw that out as a thing to think about.
Yeah, I absolutely agree with you. Then I think that's the struggle. When my role as an ethical clinician leads me in this direction and the law is saying I should go in that direction, that is exactly the conundrum that I think clinicians find themselves in, and we too often say that's tough and walk away. And I'd like to...
The difference being a good person might want to say, I want to protect this person from, I want to protect this third party from harm.
A good clinician.
Especially since this is an innocent third party, this person's kind of a scumbag, I don't really like him, so I want to protect this third party.
But a good clinician might say, I have a different obligation. So we talk to our students when we talk about professional ethics and say, it's one thing to say, you know, in my family we don't keep secrets. In my family we believe that telling the truth always and being open is the top virtue. And we say, that's fantastic, and you're going to have some negotiation to do, because when you join this family of clinicians, there's going to be a different expectation of what secrets you keep, and keeping secrets is going to be part of what you do. So absolutely, Stephen, the attention to role is critical here. A point I want to make in relation to this, and I love the way this is tied together, is that clinicians are focused on individuals, and appropriately so. The individual in front of them, or the individual right outside the door, as in the case of Gary and Jose. Ideally, legislatures are focused on groups. And so the issue being that the clinician, as a good person, might think, I've got to protect Jose. The clinician, as a good physician, may also say, I've got to protect Jose, or I have a conflict of, I also want to protect Gary, and how can I have both? The legislator might say, of course I care about Gary, of course I care about Jose, but there are thousands more just like them, and so how can I protect the largest number of my citizens, even though it is painful in any one circumstance that we're going to have losses on no matter what policy we have. And I think that's part of the conflict of focus on individuals versus focus on groups. It's part of the root conflict in some of these issues. And I want to suggest, and what I always struggle with in this particular example, is this empiric claim that people won't come for care if this is just closed. If there's no empiric evidence of that, and the community of clinicians says that's not a good reason to have that, then I would suggest doing this privately as more of a safety valve thing, and the energy should go back to the legislature saying, this is dumb public policy, that doesn't work. We need to change that law. And so I think that this is too strong of a word, but for the moment to just say, the lazy response is, I'll deal with Jose. You know, I'll fix this situation, versus, boy, I need to go back and argue about the potential harm here. the actual harm here and the false or inaccurate reasons that are driving this policy.
Right. I think I just want to take your point in actually about the role, because when you think about this issue from the clinician's perspective, what's really interesting is even if you put aside the conflict with the law, I think there's a conflict within the role in and of itself, actually, right? Because on the one hand, the physician has this obligation as a qua physician to respect confidentiality, right? That's a principle that we uphold, and whether it's absolute or not is part of the question, but that there's a presumption of confidentiality at the outset. On the other hand, you have this obligation to this other person in your clinic and it's not just this person who's out there in a theoretical way that you have no relationship to, right? And they're both your patients, which is what makes this case so challenging as a clinician. You have an obligation. On the one hand, this principle of confidentiality is telling you to do one thing within your role as a clinician, and on the other hand, your obligations to prevent harm to your patient are telling you to do something else. So even putting aside the law, there's this tremendous conflict within that role.
I would actually raise the two of you together are helping to structure an answer to the question. Yeah, you can go to the legislature, and yes, there is like a Kentucky Medical Association where you can lobby to do that. But yes, you also have a Department of Public Health, and you could add tracking to its duties. And when in our context here, what we do is we ask medical students to think about, what would you do in these kinds of cases? And part of the answer entails, this is the job that you have to turn this information over to the Department of Health, who will then go to Gary and say, we need to know all your sexual contacts, you need to be truthful, because otherwise this would then cause more ill to others as well as possibly to yourself again. And I think that, yes, there can be there can be legislation to make changes, but also in terms of the actual structure of medical practice writ large in terms of public health, can help to address that. But I do agree, though, with the notion that physicians in general need to take on and they need to embrace the role of social agency. They're supposed to be agitating, instigating change when they see injustice occur in their clinical practice. I think part of the problem is, and practical speaking, is in the trench warfare of medicine, is that you feel small and not very powerful in that way. And I don't know about Lisa in terms of, I don't really work with organized medicine within my state. I don't feel free to say, hey, there's a big problem here, let's do something about it. So I think that can be an area of powerlessness for the individual physician, where all they see is this terrible thing's about to happen to this patient, and I'm the only person who has this knowledge who can make a change to do something that'll make it a better outcome than what it is right now.
Right. Good.
Massachusetts has a strong law against breaching confidentiality. However, the only penalty for the law is civil liability, which means that the person who is aggrieved has to go out and put up money up front to get a lawyer.
Remember, Gary was a very wealthy patient.
Yes. But you're going to get Katie. And Katie is going to go in there and is going to be arguing not the law, but is going to be arguing the 12 people who are much more like Jose than like Gary. And there's something in the law called jury nullification, where the ultimate decision is what the jury thinks is right or wrong. I don't care what the law says. The jury has a right to make its own decision, which is not reviewable by anybody. If the jury acquits, it's done. And so there is in our law this outside, you've got to convince 12 people that they ought to enforce this. And we had those in the medical field. The one with the Chicago case where the guy went in with a gun and pulled the plug out and let his newborn die. And the jury acquitted. It was clearly murder in Illinois. But they said we're not going to convict. I think some of the assisted suicide cases have gone the same way. The jury simply won't convict.
They're not willing to make the role morality distinction that we make in terms of if we think it's acceptable for the physician to pull the plug, then why should it why shouldn't the family member be able to do that?
And that's an example of a jury saying this is an exception. This isn't what this statute was meant to cover. We're making exception, and I think what we're arguing about Here, what we're trying to open for conversation is when do physicians behind closed doors say this is an exception? That's an example of due process building in a safety valve for an exception. This is saying I'm not going to let it get to that. I'll take care of it. So that might be a good note to end on.
Very good.
Yeah.
Thank you very much.
Thank you.